Hi everybody. I am going today to talk to you about SARS-CoV-2 infection and the main lines of diagnosis and treatment and the management, especially for home-based patients. As you know, in late 2019, a novel coronavirus was discovered, and it started to cause an epidemic and later on declared as pandemic in 2020 by the World Health Organization. Its name is Severe Acute Respiratory Syndrome Coronavirus 2, and hence is the name SARS-CoV-2. And it started, as you know, in Wuhan, in China. So this coronavirus, it is enveloped virus with a positive RNA genome. So we have actually many RNA viruses, like hepatitis C virus is RNA virus, and HIV is RNA virus, and this virus as well is an RNA1. It is belonging to the coronaviride family. The coronavirus is not a new virus. It was discovered in 1960s. They are divided into four genera: alpha, beta, gamma, and delta. The SARS-CoV-2 belongs to the beta genus, which is the same as SARS-1 in 2003, which was beta genus as well. Coronavirus contains at least four structural proteins. As we can see, the red one here, it's called the spike protein, and the envelope protein, which is labeled as yellow, and also the membrane protein and nucleocapsid protein. The most important is the spike protein because it promotes the attachment of the virus cell membrane to the receptor, which is ACE2. So spike protein is very important in the process of virus entry, invasion into and infecting the cell. Therefore, the spike determines to some extent the infectivity of the virus. Studies have shown that the receptor protein bound to the new coronavirus in humans is likely to be to the angiotensin converting enzyme 2, ACE2 protein. Also, it is inferred that the new coronavirus binds to the ACE2 receptor with the facilitation of the TMB SS2, and through this it goes into the cell and causing organ damage. Also, it is very important to know that there are certain places in the body they are rich in ACE2 receptors. One of the places is the kidney itself, which nearly 100 times higher than the respiratory tract. And so the kidney is in danger. And also there are abundant ACE2 receptors in the intestine. And this may be the cause why one of the presentations of coronavirus is GIT symptoms as diarrhea. In this figure, this is a method how coronavirus, the SARS virus, invades the body. As you can see, the SARS virus here goes to the cell membrane, and they find the ACE2 receptors, and we have the TMB RSS2, which is tissue membrane protease SS2, which facilitates the binding of the priming the binding of the SARS virus through the spike protein to the ACE receptors, and this is also increased by ADAM17 activity, leading to infecting the cells. We will return back later on to the point of ACE2 and its relation to hypertensive patients who are under AC inhibitors. But this mechanism shows us the potentiality of therapeutic approaches to prevent the virus from infecting the cells. So if we can find a spike vaccine, which is the idea of the vaccine of Oxford, when they enwrapped the gene protein responsible for the spike protein, so the gene was wrapped in adenovirus from chimpanzee, which is non-infectious to human, and injected, trying to generate antibodies to block the spike and consequently prevent the binding of the spike to ACE2 receptors. This is one of the options. So spike vaccine is an option. The other is to try to find a TMPRSS2 inhibitor, or to block the ACE2 by ACE2 receptor blocker to prevent the binding of the spike to the ACE2 receptors. So all these things are potential possibilities to try to find new medications. So understanding the mechanism of cell invasion can help to try to find a certain drug in this battle to help to prevent virus infection. The incubation period of COVID-19 may be as long as 14 days, with most cases occurring 4 to 5 days after exposure. As we know, pneumonia is the most frequent serious manifestation of infection, with approximately 15% of patients developing severe infection expressed by hypoxia, dyspnea, or extensive pulmonary involvement. In addition to fever, cough, and or dyspnea, there are other features including some upper respiratory tract symptoms, myalgia and fatigue, diarrhea, loss of taste and smell. They are also common. We don't have a specific clinical features that can reliably distinguish COVID-19 from other viral respiratory infections. And here is a tricky point that, yes, in the light of the epidemic, we should consider the first differential diagnosis of all respiratory symptoms as COVID-19 until proved otherwise. But also, we have another responsibility, is to discover if the symptoms happening to the patient is due to another disease. Acute respiratory distress syndrome is a major complication in patients with severe disease, and it can manifest shortly after the onset of dyspnea. And we have also many other complications like thromboembolic events and acute cardiac injury, acute kidney injury, and inflammatory complications. And the two main causes of death are adult respiratory distress syndrome, pneumonia, and thrombosis and pulmonary embolism. In this table, you will find a summary of the symptoms: fever, cough, dyspnea. And for dyspnea, we should realize that dyspnea may be new or worsening over baseline, like in patients who have COPD or chronic bronchial asthma, who may have chronic shortness of breath. And so worsening of over baseline dyspnea also is one of the symptoms. Anosmia or other smell abnormalities, ageusia or other taste abnormalities, sore throat, myalgia, chills and rigors, headache, rhinorrhea, nausea, vomiting, diarrhea, fatigue, confusion, and chest pain or pressure. What are the risk factors for severe disease or to get infection as well? Okay. Age above 65 years old, and for this reason, the advice was for all people who are above 70 years old is to stay home. And also, if the patient has pre-existing pulmonary disease, makes him liable to infection and exacerbation of his COPD or bronchial asthma. Patients with chronic kidney disease, patients with diabetes mellitus who are liable to have severe disease and severe infection. History of hypertension, it is one of the factors here in COVID-19. Also, history of cardiovascular disease. Obesity is a risk factor as BMI for PMI more than 30. There are some presumed risks like using biologics like TNF inhibitors or interleukin inhibitors. Despite some of them were tried in the management of COVID-19 without any proven efficacy. Also, a history of transplantation and immunosuppression puts higher risk, and also patients with rheumatological diseases who are under immunosuppression. Also presumed for HIV patients with CD4 cell count less than 200 cells per microliter or a known CD4 count. So the official advice was to try to minimize the immunosuppression for patients who are under immunosuppression due to renal transplantation or immunological diseases. But on the other hand, many of the patients who were under immunosuppression, they behaved well under COVID-19. And one of the theories that this immunosuppression helped to inhibit the cytokine storm. And this needs further analysis and further investigation to be clear. But the official advice until now that such patients who are under immunosuppression and using biologicals should be for shielding, isolation, and also they are liable for severe disease. We have also the laboratory features as shown in this label, and there is a correlation between the very high figures of lab markers and COVID-19 severity. If you look at this table, although these laboratory features are associated with severe disease, they have not been clearly demonstrated to have prognostic values, and the threshold mentioned in this table are just to identify people who are at risk for severe disease, not to say that all these figures indicate severe disease, because I think the evaluation of the patient should be a holistic evaluation regarding the clinical presentation, the degree of dyspnea, the oxygen saturation, his hemodynamics, pulse, heart rate, and fever. So all should be evaluated altogether, not just to manage certain numbers, because most of them are non-specific inflammatory markers which will go up with any inflammation. So the D-dimer increases. You know, the D-dimer is a product of the destruction of the cross links of fibrin. CRP is high. LDH goes up as well. Troponin goes up in the case of COVID-19. Ferritin, which is an acute phase reactant, of course, goes up, and the CPK as well. One of the things which happens is absolute lymphopenia, and I need to focus on the word absolute lymphopenia. It is not the percentage, but it is the absolute count, because this makes a lot of confusion. When you look at the percentage of lymphocytes and you consider the lymphocytes as low, despite the absolute count is normal. So usually we look at the absolute count. And to give an example, if you have a patient, his white cell count normally is 6,000, and the percentage of lymphocytes and the lymphocyte count is 2,000. So 2,000 is normal lymphocytic count. And but in relation to this white cell count, the percentage will be about 33%. And if the same patient, his white cell count was 10,000 and you have 2,000 of lymphocytes, which also is normal, but the percentage will be 20%. In such case, you will say, okay, the lymphocytes are low, but in reality, the lymphocytes are not low, because you should look at the absolute lymphocyte count. Regarding diagnosis, the most important one is the PCR test, which happens through swabbing the nasopharynx and swabbing also the throat. In performance of the swab, the probe should go deeply inside, not to be from the surface, from outside, because this will give false negative results. Another tests like the antibody detection. Antibody detection can't tell about current infection, but it tells us if we got the infection previously or not. There is also another test which is antigen test, and the data are limited about it. So the diagnostic test here is the PCR test, but it is of note to say that some patients may have negative PCR test and it may be false negative, and so we should, as I said previously, evaluate the whole case altogether, including the lab tests besides the clinical presentation as well. Regarding radiological testing, the advice of the International Society of Radiology is to get a chest X-ray, especially if the patients have a suspected pneumonia. Radiological testing may not be necessary if the patient has a very good oxygen saturation, no shortness of breath, and this also will minimize the exposure of the patient to go to radiology centers, which may expose the patient to more risk of infection. If the patient is not already infected and you need to confirm. Regarding the CT chest, yes, it is more sensitive than the chest X-ray, but it is not recommended as the first step. Usually the CT scan shows ground glass appearance bilaterally, and in a trial evaluated the chest CT findings on over than 2,700 patients with COVID-19. Ground glass opacification was found in 83%, and ground glass opacifications with mixed consolidation was found in 58%. Adjacent pleural thickening was found on 52%. Interlobular septal thickening was found on 48%, and air bronchograms in 46%. So if we look at the management, outpatient management in adults, okay, it is very important at the start to do risk assessment for our patients, to recognize people who are at high risk to catch the infection or at high risk to progress to severe disease. It is the same table as we mentioned before. So people who are liable to high risk are age more than 65 years, residents in nursing home or long-term care facility, because there is the liability to mix with many people, immunocompromising conditions, chronic lung disease to moderate severe asthma, cardiovascular disease, including hypertension in this case, and severe obesity with body mass index more than 40 kilograms per square meter, diabetes mellitus, chronic kidney disease, undergoing dialysis, cerebrovascular disease, chronic liver disease, tobacco use disorder. And this is very important because some people imagine that people who are smokers are protected. No, smoking also is one of the risk factors to progress to high risk, to severe disease, and put people at high risk. Moderate risk for people between 20 years and 64 years, okay, they are at moderate risk. Or if age less than 20 years with underlying medical conditions. So the low-risk people are people who are under the age of 20 without any underlying medical condition. And actually, if we analyze the mortality, we'll find that the number of people less than 20 without any medical condition is less than all the other categories. So we need to stratify the risk first of our patients, to know people who are at high risk to progress to severe disease, to give them more attention and more care, and also to know patients who are at lower risk. Number two, which is very important, is to assess the severity of the presentation. Does the patient have mild disease, moderate disease, or severe disease? This will determine the level of care we should provide to our patients. And as you can see in this algorithm, it is from the CEPM, and they classify the mild, moderate, and severe as mild, who are patients with oxygen saturation 95% or higher, and if heart rate, respiratory rate is less than 20 per minute and the heart rate less than 90. And they put moderate if they are between 93 to 94 oxygen saturation, and heart rate is slightly up to 24, and if heart rate is between 91 and 130. And they put severe as people who have oxygen 92 or lower, and respiratory rate more than 25, and the heart rate more than 131. The WHO has put another figures, and they consider that the mild COVID is a symptomatic patient meeting the case definition for COVID-19, but without any evidence of pneumonia or hypoxia, okay, which agrees with the first category. So mild have normal oxygen saturation and normal respiratory rate as well. And the WHO put that the moderate disease, or for patients who started to have pneumonia, but the difference that they put the oxygen saturation, instead of being 93 to 94, it is above 90. So if the patient is above 90% on room air, according to WHO, we can classify it as moderate. And they put the severe a bit lower than the 92 put here in this algorithm, to be if less than 90% oxygen saturation. This means that the patient has severe pneumonia, and they put the respiratory rate if it is more than 30 per minute to be severe. So in general, we need to maintain the oxygen saturation of our patients more than 90%, so between 90 and 95%. So this will make a difference in the way we manage our patients. So mild patients, they needs only just to be well hydrated and to get some symptomatic treatment for fever and pain, like paracetamol only. No indications for antibiotics, no indications for thromboprophylaxis, except if they have other risk factors. For the moderate as well, the moderate will need antibiotics to start at this stage, and the thromboprophylaxis will depend upon the risk factors. But for the severe patients, they will need for sure hospitalization. The patients who turn from mild to moderate, they will need clinical review to evaluate the condition and if they need hospitalization or not. So as you can see in this algorithm, so the color is moving from green in the mild to amber and orange for severe. One of the good points we need to mention that the physicians should be aware about what we call silent hypoxia, that some patients may drop their oxygen saturation with normal respiratory rate and heart rate and without any other symptoms. They should be watched and observed as well. So the patients who are in need for clinical evaluation to decide if they are going to stay at home or to go to the hospital and need clinical examination, they are patients with mild dyspnea in a patient with an oxygen saturation in room air between 91 to 94%, okay? And patients with mild dyspnea in a patient at high risk of severe disease, and moderate dyspnea in any patient, and symptoms concerning enough to warrant in-person evaluation, like mild orthostasis, patients dropping his blood pressure, things which are mild but not severe enough to go rush to the hospital. But other patients who are mild to moderate without any progress, they can stay at home without in-person evaluation, or can be evaluated in phone conversations with monitoring their oxygen saturation by pulse oximeter, and also their other hemodynamics. While managing our outpatients, we should emphasize on the following. Number one, importance of infection control and self-isolation. So patients who have symptoms should be completely self-isolate themselves, avoid completely meeting with others, and if they meet others, all the precautions and personal protective equipment should apply for the medical personnel visiting them. And this is very important actually to contain the virus infection. Number two, check if symptoms are caused by other disease. It is a very important point, because there is overlap between the symptoms of COVID-19 and many other common conditions, which may make a change in the management, especially with bacterial pneumonia, when antibiotic prescriptions will make difference and will be the main treatment if it's bacterial pneumonia. A number of therapies are being evaluated actually for the treatment of COVID-19, but none have proven efficacy, as we will see later on, with some potential good benefit of a few of them. The follow-up, whether face-to-face or remotely through the phone or Skype or Zoom, things should be recorded, like the heart rate, blood pressure, respiratory rate, oxygen saturation, temperature, and also alertness and mental state. And also shortness of breath should be recorded, whether it is new or worsening. Now, we are in era of telemedicine, and we have many programs that we can contact patients and speak to them and see them as well remotely. Also, one of the important points while managing patients is a follow-up after discharge. So after discharging patient from hospital, if we admit them, we should continue the follow-up after discharge to avoid any later complications. So what is the management algorithm? So number one, we'll talk about fluid balance. This applies to all stages, mild, moderate, and severe. We encourage patients for oral drinking, but aiming at euvolemia, to have normal water content of the body. So we need to avoid dehydration, and at the same time, we need to avoid fluid overload, because this may be risky for them, especially for people with certain conditions who have a tendency to build up fluids in their systems, like patients with heart failure, patients with nephrotic syndrome, patients with liver cirrhosis. So we should encourage patients for oral drinking, but to keep themselves euvolemic. It is preferable to ask educated patients to have fluid chart to evaluate the amount of fluid they take, and also the amount of urine they pass, because some cases have the acute kidney injury, so we should keep an eye on the fluids. Intravenous fluid support can happen in patients who have poor oral intake, or patients who are dropping their blood pressure less than 90 millimeter mercury, or hypotensive patients who present with shock. Of course, they will need intravenous fluids. Of course, be careful in patients with heart failure and chronic kidney disease, because they may not tolerate intravenous fluids, and this may lead to acute pulmonary edema. So this should be taken with caution. Second, symptomatic treatment, which is actually applies to mild COVID infection, give antipyretics and analgesics. The best is to give actually paracetamol. Regarding the ibuprofen, there was some debate at the start of the epidemic due to some anecdotal reports that ibuprofen and non-steroidal anti-inflammatory drugs worsen the condition of patients infected with COVID-19. We don't have strong evidence about this. So in the presence of lack of evidence, it is preferable to focus on paracetamol. But some guidelines, like the PMJ best practice guidelines, suggest to, if indicated, to use a small dose ibuprofen with small dose and short duration. But we need to use this with great caution, especially in patients presenting with hemoptysis, or patients showed bleeding tendency anywhere, or patients who are on treatment doses of anticoagulants. Also, regarding some symptomatic treatment, inhaled bronchodilators are recommended only in patients with asthma and COPD, but don't start new bronchodilators except if you have wheezes. The third line of treatment is oxygen therapy, which is very important for patients who are dropping their oxygen saturation. So this doesn't apply to mild cases when the oxygen saturation is usually 94 or above, but it applies to people dropping their oxygen saturation down to the moderate range, or of course the severe. So for people who are dropping their oxygen saturation less than 93%, or in another schools they less than 91%, okay, and people who are less than 90, for sure they should have oxygen. And usually we start the oxygen at a low flow, giving about 2 liters, and see what is the effect, trying to keep the saturation around 94%. And gradually we increase the oxygen gradually. So if his patient is dropping and we check by the oximetry and find that he is dropping his oxygen saturation, which was maintained around 95% on 2 liters, started to drop again, we can increase gradually to 4 liters and so on. And the increase in the need for oxygen indicates deterioration. So if your patient starts to need more oxygen, this means that this patient is deteriorating. The fourth line is antibiotics. Antibiotics also don't apply to mild cases because there is no evidence of pneumonia. But from the moderate and severe, antibiotics can be prescribed. It is a viral infection, so the antibiotics themselves will have no effect on the virus, but it is for associated sepsis and associated bacterial infection. For this reason, we manage the antibiotics here as the same management we give antibiotics as per community-acquired pneumonia. And for sure, this will be different from certain place in the world to another place. So, for example, in UK here, so the first choice is to use amoxicillin and doxycycline with other alternative antibiotics, and if severe case, we can use levofloxacin. But of course, in other places of the world, they should follow their local epidemiologic and cultural studies because of the bacterial resistance, which will make difference between antibiotic choice between one place and another. But it is recommended to be careful about the choice of antibiotics, not to abuse the antibiotics in cases with no evidence of infection. Don't give many antibiotics, because this will lead to increase the bacterial resistance, which will be a very high cost and high price we will pay more later. The next line, which is the fifth line of treatment, is venous thromboembolism prophylaxis. We give low molecular weight heparin unless contraindicated, like in very low platelet count, and I have made another specific video to explain the thromboprophylaxis, so please watch it. There are some advice about the ACE inhibitors, because there was some discussions about if ACE inhibitors are and ARPs are risky for patients due to the AC2 receptor, which is the main receptor and main vehicle through which the virus is internalized to inside the cell. And as we can see from this figure, as we know, angiotensinogen will be transformed into angiotensin 1 through the renin, and angiotensin 1 will be converted into angiotensin 2 through the ACE. And as you know, ACE inhibitors works here at the enzyme, angiotensin converting enzyme, to decrease the formation of angiotensin 2. But angiotensin 2 itself works on angiotensin 1 receptor. It has high affinity to angiotensin 1 receptor, not to angiotensin 2 receptors. So this will leave more expression of angiotensin 2 receptors, which are receptors for COVID-19. So the recommendation was not to stop the ACE inhibitor or the ARP if the patient was already on them, but also don't start new ACE inhibitor or ARPs if the patient was not taking them. And so it is very clear. So we will not deprive the patient from the benefit of ACE inhibitor or angiotensin receptor blockers if patient was already on any of them. But at the same time, because we of this concern about the ACE inhibitor, don't start new patients on it until the pandemic subsides. Another advice as well, it is about the nebulizers. So patients should be advised not to use nebulizer medications, especially in the presence of others, and we can shift them to metered dose inhalers to avoid spread of infection. For patients who are under immunomodulating medications, immunosuppression, transplant patients, glomerulonephritis patients who are under immunosuppression, or under rheumatology for collagen disease, stopping the immunosuppression or stopping the steroid should be discussed with their specialist to assess the risk. Of course, in case of transplantation, we can't stop the immunosuppression completely. But actually, this can be assessed by the transplant doctor and the nephrologist to minimize the dose according to the immunological risk of the patient. So this should be put into consideration. If we look at the medications we tried to use in the management of COVID-19, we'll try to use azithromycin and hydroxychloroquine. It proved to have no effect. And please don't combine azithromycin and hydroxychloroquine, because beside it causes no benefit for the patient, at the same time there is risk for long QT syndrome, which can cause serious fatal arrhythmias and can lead to sudden death. So this combination is not correct, especially in people with cardiac risk factors for long QT syndrome. Also, lopinavir and ritonavir, it showed no effect. Favipiravir, no effect as well. Tocilizumab as interleukin-6 inhibitor, no proven efficacy. And ostelimavir, the Tamiflu, which we used to use in the SARS previously, it is not effective. And also vitamin D, it showed no effect. There is also no rule for vitamins like vitamin C and zinc and vitamin D, as people in certain places in the world use, claiming that it may be immunostimulant. In reality, we don't have a drug called immunostimulant in our pharmacology box. We have only immunosuppressive drugs, not immunostimulants. So what are the drugs now available which proved some efficacy. We have the remdesivir and dexamethasone and convalescent plasma. So regarding remdesivir, there was a multinational trial of about 1,000 patients with confirmed COVID-19 and the pulmonary involvement. Remdesivir resulted in faster time of recovery. The median was 11 versus 15 days with placebo. The trend towards lower 14 days mortality actually was not statistically significant, 7 versus 12%. But when subgroup analysis was done, there was a reduction in the mortality with remdesivir among patients who required ventilatory support and oxygen and high flow oxygen, which means that severe cases can get benefit from remdesivir. I think this also applies to the dexamethasone. We had the recovery trial, and the recovery trial investigators have produced actually a manuscript preprint telling us that dexamethasone at a dose of 6 milligram once daily can have a good effect on patients with COVID-19, and low-dose dexamethasone reduced the 28-day mortality among patients hospitalized for COVID-19 compared with the usual care alone. And in subgroup analysis, actually, the relative reduction in mortality appeared greater among patients on invasive mechanical ventilation than among those on non-invasive oxygen therapy. And so there was no mortality benefit seen among patients who did not require respiratory support, which may be due to the effect of steroid in the management of ARDS, adult respiratory distress syndrome. Dosage suggested is to give 6 milligram once daily for 10 days until hospital discharge. And the point of dexamethasone here puts a very important question. Does systemic corticosteroid treatment at initial phases of COVID-19 prevent the immunopathology seen in severe cases or not? And there is no recommendations at all to use steroid and systemic corticosteroids in non-critically ill patients. Okay, so I want to give some comments on this. So first of all, during the SARS outbreak in 2003, corticosteroids didn't change the course of the viral infection and delayed viral clearance, which is a drawback to delay the clearance of the virus. And as I mentioned at the start, that the SARS outbreak in 2003, was the same genus like the COVID-19. But on the other hand, a retrospective study was published later on after SARS in 2007 in Hong Kong, suggested that there was better survival in patients treated with prednisolone for mild pneumonia or methylprednisolone in more severe cases. Recently, Chinese experts stated that in COVID-19 patients, systemic corticosteroids should be considered on individual indications in a low to moderate dose and for no longer than a week. And this was a Chinese suggestion. But the National Institutes of Health and their COVID-19 treatment guidelines, they are against the use of systemic corticosteroids in non-critically ill patients. Okay, so the advice now is against the use of systemic steroids, and the only evidence now we have is dexamethasone for people who needed respiratory support and ventilation. So systemic steroids should not be used routinely in COVID-19 patients, but it can be used in the normal context. What I mean, like in cases of exacerbation of COPD and the bronchial asthma, as we use it in the exacerbation, which is normal medical indication. Also, it should be continued for managing people who have immune disease or renal transplant, as usual. And hydrocortisone can be used in cases of septic shock, not responding for fluid management. It can be used also for pregnancy and breastfeeding in case of ARDS. These are the normal medical indications we have, but there is no recommendation at all to use corticosteroid and to use prednisolone in patients with COVID-19, apart from the dexamethasone indication for hospitalized patients who needs respiratory support and ventilation. And as you can see, the dose is only 6 milligram per oral for only 10 days, which is a small dose. Also, using steroid will put certain precautions. So what about people with diabetes? If steroid is prescribed for people with diabetes, they should be shifted to insulin treatment and be under close observation. Otherwise, they may go into diabetic ketoacidosis, which may be sometimes fatal. And so patient may die due to DKA rather than the COVID-19 itself. And also, we should be careful about prescribing steroids in people who are known to have peptic ulcer disease to avoid activation of the ulcer and getting hematemesis. But in general, there is all the advice now and is against the use of steroid routinely in patients with COVID-19. So returning back, so we mentioned about some of the medications which showed some efficacy, like the remdesivir and the dexamethasone in intensive care situation, and also convalescent plasma for COVID-19. So convalescent plasma from individuals who recovered from COVID-19 may provide some clinical benefit when given early in the course of the disease. There was an open label trial from China. They tested 103 patients with severe life-threatening COVID-19. And addition of convalescent plasma to the standard treatment improved the rate of viral RNA clearance compared to standard treatment alone, but there were no statistically significant difference in the overall rates of clinical improvement or survival. However, the trial was stopped early as local cases subsided. So there may be a benefit for convalescent plasma when given early in the disease, and other trials are ongoing to decide about this. So in summary, mild cases should be treated by home isolation, monitoring, and symptom management with antipyretics and analgesics. And moderate cases should be also have self-isolation in the monitoring and symptom management supportive care, but we should add antibiotics. In the first two stages, mild to moderate, the thromboprophylaxis should happen only if the patient has a risk factor. For severe cases, they need hospital admission. This is the first issue. They also need oxygen therapy. They need thromboembolism prophylaxis. They need antibiotics. They can have dexamethasone to improve the outcome, getting antipyretics and analgesics as well. And for people who continue to need very high flow oxygen, they will need artificial ventilation as well. We mentioned that there are only 3 drugs now with possible proven efficacy. I'm saying possible because now COVID-19 is a new infection, and our knowledge about it changes every day. So using the remdesivir can give some benefit, which had compassionate FDA approval, and also dexamethasone and the for people who needs respiratory support and ventilation. And the third one is convalescent plasma, which may give early effect if given early to the patient. I hope this may be helpful to outline the lines of management of COVID-19, and thank you.